going to try and be brief. I'm going to try and be brief and describe how I started, found out I had prostate cancer, and the various phases of my case history. Oh, okay. Okay, so I'm currently 71. I live in Rancho Penasquitos. I'm an aerospace engineer, so you may notice a lot of numbers and stuff on my presentation because that's what I do. And right now, my cancer, after complete local treatment, is metastatic, but it's still castrate sensitive, and my PSA is around 0.16. My biopsy on the full gland when I had surgery was Gleason 9, and I'm now stage 4. And my current treatment is ADT, Lupron with Zytiga. And actually, I feel pretty good right now. I get hot flashes from the ADT and a little fatigue. My workouts are harder. One of the things that I've done since I retired is work out at the gym, try and keep my bone density up and my muscle mass. All the doctors advise that. Also, I've reduced my weight some. So this is the history in a nutshell of my PSA. I did it on a log scale, so because after I had the surgery, which was right about here, when I went on treatment, now it's down here in the range of 0.01 to 1. But when you've still got a prostate, the normal range is from 1 to 4, which right here is when I had my first biopsy, and that was fun. And then my second biopsy, I was on active surveillance here. And then I went on full ADT, then surgery, and then radiation, and now I'm on ADT. So this shows the history from when I started at age 60. I decided I needed to get a regular physician, and I told him I had BPH and had some urinary problems. So he put me on every year he was going to test me for PSA. So I had a 1.9, then 2.5, then 3.0. You can see a not good trend here. And finally, in 2012, I had a 4.2. So my doctor says, well, you got to go see the urologist. So I went and saw the urologist, got my first biopsy, and I'll tell you about that. And then 2 years later, I had my second biopsy, and that was bad news. So this summarizes what I just said. I had up through age 60 in my late 50s. I had frequent urination and BPH. I couldn't sit through long meetings without a break. And then in 2012, my PSA was the first time greater than 4, which was the threshold for saying there's something wrong there. It was 4.2. So the urologist did a DRE, which just this little cartoon down here, invading my personal space. And he says, well, I can't feel anything, but you're still above the limit, so we're going to give you a biopsy. Little did I know what a biopsy entailed. This is a picture of what they do in the biopsy. They stick this thing up your rear passage, and they have a ultrasound probe and a biopsy gun that fires needles through the side of your intestine into your prostate, and it hurts like hell, really. I mean, I've talked to people about this, and most guys try and man up and say, "Oh, it hurts a little bit, you know." Baloney is right. But this is serious because, you know, a biopsy is an important thing to tell when something is really going wrong. You have to know that there's cancer in there. I think the urologists need to get their act together and figure out that this thing hurts and we better use some serious anesthesia on it. The other thing is that I think that this is inherently a risky business because you're perforating the side of the rectum, and there's all kinds of blood leakage and infection chance there. They tell me that there's another way that they can do this, where they, instead of going through the anal passage, they go through the bottom pass between your legs, and that has less chance of infection. Anyway, I had a course of antibiotics, and the result of this first PSA and DRE and biopsy was 1 core out of 12 had a 3+3 Gleason. So I said, gee, that doesn't really sound serious. I mean, it sounds like I ought to pay attention, but I went online, of course, and I found this group here, plus a lot of other stuff online about this, and looked up the 3+3 Gleason, and then they said, well, that's barely cancer. I mean, it's really, and now they're saying, well, maybe it's not really, shouldn't be called cancer. So I said, I'm not gonna, the doctor says, the urologist wants to refer me to a surgeon or a radiation. He sent me over to talk to Rossi at Proton Center, because they were trying to fund that. And I mean, he said, I don't really think you need proton treatment, but my boss says I got to refer patients over there. So I did some research. I went to a couple IPCSG meetings, and I decided to go on active surveillance. The problem with active surveillance is the doctor that you're dealing with and the institution need to be committed to active surveillance. They need to get you scheduled in to have periodic checks. Also, I think this has some relation to the biopsy problems, is they don't want to do biopsies as frequently because of all the pain and risk of infection and damage. I think if you listen to what Bernadette said at the last meeting, a multi-parametric MRI or imagery would be a much better way of tracking without taking all the risks of a biopsy. And also, it wouldn't drive people away, because a lot of guys, they get that kick in the ass from the first biopsy, and they say, well, I think I'll just take my risk, but the cancer. So after gradual increase, my PSE reached 7.7, and I went in, and the doc says, uh-oh, did the DRE, and he found a nodule. And I had a full-blown 4+ floor Gleason with full gland involvement. And I said, well, how did it get so high so quick? I thought I was being surveilled and you were checking. And well, then they did an MRI and they found that there were capsule extensions, but they also did a bone scan, and they said, no bone scan. So this is what my data from the biopsy looks like. This is the cross-section of the prostate, and I got this off online when I was doing my research. And I mean, the pathology report that you get just lists all these places, and it gives you a Gleason score. And what I've done here is I've plotted it so that, like, the apex, which is the bottom, down to the base, so that's up, down, and this is right, left. So you can see the whole right side of my prostate was Gleason 8. Actually, this Gleason 6 over here of the left, on the left side, that's where the original core on my first biopsy was. So it was still 6, but somehow this whole other area had developed into a full-blown cancer. And this shows the percentage of each core that was cancerous. So you can see that 90%, 95%, that's bad. So I considered radiation, surgery. I went to talk to Dr. Rossi. He was very nice, but I wanted somebody that was an experienced surgeon that did lots of surgeries. And so I selected Dr. Chris Kane over at UCSG after doing some talking and some research. And I got a robotic prostatectomy. It didn't go anything like this, luckily. But before they did the surgery, they wanted to get the PSA down, so they put me on Lupron. And they wanted the biopsy scars to heal. Now, this would be another reason why this frequent biopsy might be a problem, because, I mean, 6 months is a long time to wait to do surgery when you look at how fast my PSA was going up. And that may have made the difference between getting it with the surgery and missing enough so that it still around. So anyway, I went in for surgery. I went in on the morning of one day, had the surgery in the afternoon, spent the night in the hospital, and got out the next afternoon. A few weeks later, I got the full pathology report, and I had positive margins, bad news. And my Gleason went from 4+4 to 4+5, and the full gland was infected. And I also had a deciphered genomic test, which indicated there was a high risk of recurrence, and it was aggressive. And some of the other effects of the surgery was because they cut out like about 2 inches of your urethra and pull your prostate up, or pull your penis up, you get shortening. And also because they tried to get these margins, I got full erectile dysfunction. I don't get any of that now. So anyway, other than that, the surgery was pretty effective. After 2 weeks, I got the catheter removed, and joy, I could control it. I had stocked up on Depends, and I was all ready for leakage, but Dr. Kane did a good job on that, and I had no problems with incontinence. And after 6 weeks, I got back in the gym. He was very adamant about waiting this long because he said he wanted to make sure all the stitches healed around the bladder and so forth. So that was good. So here's the events. Had the initial ADT after I was diagnosed. I took the first was a 1 month shot because I wanted to see how bad it was going, and I said, well, it's not so bad, so I took a 3-month shot after that. And I got my PSA way down to almost less than 0.01, and then I had the surgery. And then I came out of the surgery, and my first couple of measurements were undetectable, so I said, hooray, it's gone. But it wasn't. It starts coming back. It got up to about 0.18, 0.29, And so they wanted to do salvage radiation therapy. Now I said to them, you know, you already cut out the prostate, so it's probably somewhere else. How do you know where to shoot with your radiation? And they said, well, standard of care, Dr. Sandhu at UCSD, is we bombard the bed of the prostate. So I went through a full course of surgery, salvage radiation therapy. Didn't affect my PSA at all. And I'm convinced that it really didn't do anything. Anyway, after the radiation, my PSA kept going up. And so in January of this year, I got a C11 PET CT scan in Phoenix at PMI, Phoenix Medical Imaging, I think it's called, for Dr. Almeida. And the initial evaluation of the scan was, well, it looks like it's all localized to the pelvic region, so you might be a candidate for radiation and get it all down there. So I say, okay, I'll schedule up radiation therapy and see if I can get that. So I scheduled an appointment with a radiation therapist, Dr. Rossi, and give him the imagery that I got from Phoenix. He's worked with Dr. Almeida before, so he looked at the imagery report and said, well, the final pathology indicates that you have widespread metastatic lymph nodes that are affected, and so you're not a candidate for radiation. So I was very depressed after that, because I was thinking maybe I could zap it. So I went on full-blown ADT with back to UCSD, and they wanted to put me on just plain ADT, and they switched for some reason from Lupron to Trelstar. I don't know why, but anyway, at least my cancer is still responding to ADT, so my PSA is going down. This is a summary of my salvage radiation, and this is a little certificate you get on graduation day. And this is the scan. This is copied off one of the DVDs you get from Phoenix PMI, and it was worth it to me, but it was kind of expensive. It was $3,000. And they said, well, of course you could get but it wouldn't be a full indication of what was going on in there. Okay, so now I'm on ADT. Well, I've had several rounds of ADT over the various phases of treatment, including ADT with surgery, with Lupron. And I've had the regular things. I watch TV and I'm sitting there and suddenly, hot flashes. And I get tired in the afternoon and early in the evening. And I also had it with my salvage radiation. And then when my PSA was rising, I went back to UCSD and they put me on 3-month Trelstar with no supplement. And I didn't want to just stay on plain ADT because all the research that I've seen says it just slows it down. And with my cancer, I figure eventually it's going to come back, and when ADT doesn't work anymore, I'll be in real trouble. So I switched to prostate oncology specialists, Dr. Schultz and Dr. Lamb up in Marina del Rey. I got a bone density and a cardiac stress test before I went on full-term ADT, because bone density and cardiac effects are things you have to watch during ADT. And first I got on Lupron plus Casodex, and that wasn't too bad. But then last month, I switched to Lupron and Zytiga. Lots of dollars for Zytiga. Zytiga is made by Johnson & Johnson, and they have a foundation that will support people who don't have insurance to get Zytiga, and they only have to pay $10 a month. But since I had insurance and I had a copay, they said I could afford the copay. But it's still a significant amount of money. It's the Zytiga without insurance cash price is $10,000 a month. And this is this paper that I looked at really summarizes the evidence as to why ADT plus Zytiga and prednisone is worth it, and it's worth it to me. I mean, I saved all my life, so I got enough money now I can afford this, but it's really going to be difficult for people that don't have the money. They tested it on over 2,000 men, and every one of them, all cohorts, it improved the survival rate. And it did have a few cardiac, vascular, and blood toxicity effects. This is the link to the paper. And here they broke it down, the effects from the Stampede and Latitude tests. These were reported at the American Society of Clinical Oncologists conference this last spring. And 1 would mean there's no difference. Just if it's greater than 1, its ADT plane is just fine. This shows that in just about every case with AAP plus ADT, you get significant differences. The only group that had slightly marginal result were for those greater than 75. So, conclusion, I'm keeping going to IPCSG. I'm keeping my records up to date. I'm keeping researching online and in books, and I'm keep fighting. And the bottom line I learned through all this process is it's up to me. And like Gene said, it's the doctors know lots of stuff, but they have lots of patients. So you have to be your own case manager. So I do lots of research, and I'm not ready for this guy yet.